Thank you.
So you need to push continue on that if you're getting recorded.
Okay.
Mary, we've got it under control. Okay, so we're coming. Hello, I guess we're live now. We have the number of participants increasing, and this is John Slattery. I'm the Vice Dean for Research and Graduate Education in the School of Medicine. And we'll wait just a minute and see if the number of participants rises a bit more. We're just on the hour right now. And of course, it's academic custom to arrive 3 minutes late. So we'll give folks a chance to check in.
That's one of my favorite academic customs.
Yeah. I think we will go ahead and start. Let me introduce Dr. López. Jose has had an interesting career, and I think for the trainees, his progression is a little bit mobile. And he started actually with taking a BS in chemistry, summa cum laude, from the New Mexico Institute of Mining and Technology, and immediately became more biologic, taking his MD, again, summa cum laude, from the University of New Mexico in Albuquerque. He then started his relationship here with Seattle and the University of Washington, doing his internship and residency, and also a research fellowship here at UW. He then went on to a postdoc senior fellow position in the Department of Biochemistry. As he finished that, moved down to the Gladstone Institute in San Francisco and joined the faculty at UCSF. He then decided to move to Texas, take a position at the Baylor College of Medicine in both medicine and molecular and human genetics. He also, interestingly, took a position as an adjunct associate professor in bioengineering at Rice University. He was at Rice for several years, becoming a professor, and then also vice chair of the Department of Medicine for Research at Baylor. He then left that position to become executive vice president at for research at the Puget Sound Blood Center, which later became Bloodworks. At that point, he rejoined the University of Washington, taking a position as professor both in medicine and biochemistry. He continued becoming chief scientific officer at Bloodworks in the Puget Sound Blood Center. And now, though, he's had enough of administration. Jose, I admire you for that. And he's gone back to the bright side. He's left the dark side and the dark force, and he's continuing as a scientist at Bloodworks and with his appointments at UW as a full member. Jose, has had an outstanding career. He's received a lot of recognition. We're very fortunate to have him with us today. He's a professor. His work throughout this period has been the molecular basis of the interactions of blood cells with the vessel wall and the physiologic and clinical consequences of those interactions. He's going to be talking to us today on the title Biological and Medical Significance of Vessel Wall Adherent von Willebrand Factor. I'd like you, as you have questions, I think Jose will just go ahead and give his talk. I'll be monitoring the Q&A, and we'll really come to the questions at the end of the talk. Please put your questions into the Q&A rather than the chat function. Thanks. Jose?
Thank you very much. I just wanted to tell you, though, that I have gone back to the dark side and am once again the Chief Scientific Officer. I'll share my screen now. Okay, can you see this okay?
Yes.
All right. So what I'm going to talk about today is the biological and medical significance of vessel wall adherent von Willebrand factor. For those of you who don't know what von Willebrand factor, oh, this is not advancing. Okay. Okay, I think I can do it. All right. For those of you who don't know what von Willebrand factor is, it's the largest protein in the blood. It's protein made in endothelial cells, which are the cells that line the blood vessels that you can see here. And it's secreted from granules in those cells. And platelets are very vital for the maintenance of vascular integrity. So they're just basically going along surveilling the blood vessels for defects. And when they find them, as is shown down here, because of, say, a rupture of a plaque or because of a cut, those platelets will bind to that surface and roll along it and then stop and flatten like a fried egg and spread to cover as much of that surface as possible. They do that by recognizing adhesive molecules on the surface. And one of those very important ones is von Willebrand factor. It binds to a platelet complex called the glycoprotein 1b95 complex. I worked on this complex for much of my early career. After the platelets flatten out, they become activated. They expose activated integrins on their surface, and they bind each other through an intermediary of fibrinogen or von Willebrand factor. And that allows the formation of a plug that then can plug up a vessel if it's transected, or can, say, for example, in a heart attack, it can lead to the occlusion of the vessel and a death of downstream tissues. Von Willebrand factor, as I said, is an enormous protein synthesized in only two cell types, endothelial cells and platelets. And there it's stored in either the viable Colati bodies of endothelial cells or the alpha granules of platelets. It is synthesized as a precursor of 2,813 amino acids, so it's a big, big protein. But it gets even bigger because after it's taken into the endoplasmic reticulum, it forms these dimers through C-terminal disulfide bonds. Those dimers are then transported into the Golgi apparatus, where a very large propolypeptide at the end terminus of each of the monomers catalyzes another disulfide bond formation, which is between cysteine residues at the end termini of the molecule, and therefore this protomer, the dimer, becomes a long protein that is associated tail to tail and head to head. And there it's stored in the granules, and the propolypeptide is removed. From there, it is secreted into the plasma, and there it encounters very large forms called ultra-large VWF, and there it encounters an enzyme called ADAMTS13, and that enzyme is able to cut the very large multimers into smaller ones, and I'll talk a little bit more about that. So if you examine the plasma of normal people and you run a gel, this is an agarose gel that is necessary because of the enormous size of these multimers. What you see is a ladder of multimers. At the bottom of the ladder, it's a dimer of two VWF monomers, and this has a molecular mass of approximately 500,000 Daltons. Each successive band as you go up has an additional 500,000 Daltons. So, and some of these, I can count 16 distinct bands. That top band in this case would be a protein of a molecular mass of around 8 million Daltons. And in fact, much bigger multimers have been described, particularly in disease states. This protein is cleaved by the ADAMTS13, as I already mentioned, which is a metalloprotease. And that cleavage only only occurs in the plasma and only when the von Willebrand factor is unfolded to expose a cleavage site, and that requires fluid shear stress. So when you think about medicine, you can think about the extreme phenotypes of associated with von Willebrand factor. On the one hand, you have the phenotype of no protein or a dysfunction of the protein, and when you don't have it, the result is bleeding. This is called von Willebrand disease, and it was described by a Finnish physician called Erik Adolf von Willebrand in 1925, when he found a family of people with a bleeding disorder in the Åland Islands off the coast of Sweden. This is actually now the most common human genetic bleeding disorder. At the other extreme of the phenotypic range, you have the case when you have no regulation of those very large multimers, which are very adhesive, and you have thrombosis in the small blood vessels. Thrombosis being the formation of blood clots. And this causes a disease called thrombotic thrombocytopenic purpura, or TTP. And it was described around the same time as von Willebrand disease by a New York pathologist called Eli Moskowitz in 1924. So there are many factors to consider in assessing the function of von Willebrand factor. And among those are its concentration in the plasma, the composition of its multimers, because the larger multimers will have more hemostatic property, a specific activity. There are some multimers that for some reason, because of post-translational modification, bind platelets better. And today I'm going to tell you about something that's not very well appreciated, but it's the ability of these multimers to self-associate. I'll describe that now. So about 20 years ago, I was working with my colleague Jingfei Dong at Baylor and at Rice University, and we were studying the interaction of platelets with endothelial cells under flow. So I was already working with a bioengineer there. And what we found is if we took platelets and washed them and then perfused them over a surface of activated endothelial cells, the platelets would form these long beads in this string-like structure. And this one here contains about 100 platelets. If you looked at whether or not this could possibly be a single von Willebrand factor multimer, you'd have to think of it this way. The protomer length of von Willebrand factor, the protomer being two attached to each other at the C terminus, is 120 nanometers. A multimer with 16 protomers is about 2 microns. Okay, so you can see over here that this bar, that's 100 microns. So, and there's about 20 of these. So this is about 1,000 times longer than a protomer with 16, than a multimer with 16 protomers. So we reasoned that perhaps what was happening is that as these strands were being secreted by endothelial cells, they were getting caught in the flow and they were binding each other, and that allowed the formation of these long ropes oriented in the direction of blood flow that were able to bind platelets. And in fact, this is what happened. At the same time, there was another laboratory that started to describe that von Willebrand factor was able to self-associate the individual multimers. So that is something that we have been studying quite a lot since then. And here's a study that we did with Ying Zheng, who's a bioengineer at University of Washington. She's able to make these blood vessels in vitro that are lined with endothelial cells and have many of the properties of actual human blood vessels. And what we did with, we're now studying a blood vessel that has the geometry depicted here. And what we did was we activated the endothelial cells and we perfused with blood that had labeled platelets. And what you see here is the release of von Willebrand factor and the binding of the platelets to that released von Willebrand factor. And you can see that these massive gobs of von Willebrand factor come out of the out of the endothelial cells, they bind platelets, and slowly they become detached and they embolize. And that detachment is a consequence of cleavage by atom TS13. So this is quite a dramatic thing. These are like giant nets that can catch platelets. And they look very much like mucus in a way. And in fact, von Willebrand factor is related to mucins. By electron microscopy, one can see that there are strands that are formed in the direction of flow. And these strands are composed of smaller strands attached together that sometimes converge and sometimes diverge. And these attach these platelets to the surface of the intact endothelial surface. This is the first time we were the first ones to describe that the platelets could actually attach to von Willebrand factor on the surface of endothelium. Now, if you do an experiment like the one I just described, but in the absence of blood and just perfuse buffer through there, you can see that the VWF will form these long strands within the blood vessel. And these strands, when you come to a bifurcation here, where flow comes here and here, can sometimes actually span the lumen of the blood vessels. And in this case, you've stuck a rope from one vessel wall to another vessel wall, and this is approximately, and the longest span that we could note was about 300 microns. You can see on the right that von Willebrand factor strands are at the bottom of the vessel, at the top, and right in the middle. Especially in the middle, it's where it needs to span a blood vessel. So you can imagine that if blood was coming along, red blood cells and other cells could become sheared on these strands, which are like razor wire. These are very much like spider silk as well. And here again, here's an electron micrograph where you can see the strands again diverging and then associating there. In a straight tube, what we see when we see, so here are the Weibel Palade bodies, those granules, and you can see that there are individual strands being secreted, and then they come together downstream in the direction of flow. So here's, for example, here's a strand that's coming along, and then this strand will join it. Of interest, when you curve the vessel, then all the strands will go into the inner curve of this. So essentially, the strands you can form continuous strands that can go all the way through for a long way. And it's going through the shortest distance that flow could travel through there. And you can see that they accumulate here on the inner curves. And these strands can reach enormous lengths. In this case, we have one continuous strand that reaches a length of approximately 5 centimeters. That's not millimeters, that's not microns. That is a macroscopic strand. So what we understood that these VWF multimers were self-associated. Some of them were becoming attached to the surface of the wall. And what we knew is that would happen, that was facilitated by shear stress. But the other thing that facilitated that was the presence of flow acceleration. So here you have a vessel that goes from a larger lumen to the smaller lumen. Because of conservation of flow, what will happen is that as it enters this smaller diameter lumen, the flow will accelerate. And right there in the region of acceleration is where you have VWF plastered onto the surface of the vessel. We also tested whether von Willebrand factor that was in circulation could attach to von Willebrand factor that was adhered to the wall. So what we did was we perfused red VWF, red labeled VWF, into a vessel that had been activated, and there were already preformed strands. And you can see here that the von Willebrand factor from the fluid phase attached to the VWF that was already there, and it attached on the upstream surface. What are the consequences of this? Well, here we have a grid vessel, a vessel that looks like this. And what we've done is we've activated the endothelial cells in this vessel, and then we've perfused platelets that are labeled here in magenta. And we've followed the accumulation of platelets on the vessel wall. So here we have essentially normal plasma with a control antibody that doesn't bind anything. And you can see the platelets attaching, but they don't really accumulate, and that's shown here. If we add this antibody A10, which is against the metalloprotease ADAMTS13 that cleaves VWF, what we have is we have continual accumulation of platelets on that vessel wall to the point where eventually this vessel wall will become, this vessel will become occluded. And here you see just the continual accumulation of platelets. If we add an antibody against the platelet receptor GP1B, you can completely prevent the accumulation of these platelets. And this is a model of that microvascular thrombotic disorder, TTP, that I talked about. Now, if you look in one of these regions where you can see in green von Willebrand factor and in magenta, you can see the accumulated platelets, you can look there by phase microscopy. Not only do we have platelets accumulating, but we have actually massive adhesion of red blood cells to this surface. So this is actually a multicellular clot. And of interest, if we add that antibody that prevents the binding of platelets, it essentially prevents the binding of red cells, which indicates to us that the red blood cells are binding maybe a few of them directly to the von Willebrand factor, but they're binding more to the adherent platelets. So that's a contribution of red cells to that thrombus. In addition to the red cells, when we look at here, this is a blocked vessel. You can see the VWF here in green. You can see platelets stained with this antibody in white. And you can see, in addition, within this thrombus, that you have a lot of nuclei. Okay, so nucleated cells in blood are all leukocytes, white blood cells. So leukocytes also accumulate in these VWF platelet strings. So is there anything that can regulate this self-association of von Willebrand factor? We had a clue about that when we note that if we purify von Willebrand factor, so biochemically pure von Willebrand factor, and we put it in a test tube and stick it in the refrigerator, after a couple of days, there's no more VWF in the solution. You can accelerate that loss of VWF from the solution by adding a low concentration of urea, which denatures the protein. And you can see here that after 4 hours in this test tube, that the von Willebrand factor is gone from the solution. If, however, we don't purify it, or we add something that's in plasma, and it's even in boiled plasma, you can see that the VWF is there at time 0, and it's still there at 4 hours, as opposed to here. So this is kind of boiling down many years of work to figure out that that boiled plasma contains something. And it turns out boiled plasma only has three proteins in high concentration, because the rest of them precipitate with the boiling. And these three are the ones: alpha-1 acid glycoprotein, ApoA1, and prealbumin. And of these, the ones that had the VWF protective effect is the ApoA1. ApoA1 is an interesting protein, apolipoprotein A1, because it is the primary apolipoprotein of high-density lipoprotein. High-density lipoprotein is better known as the particle that carries the good cholesterol. So it's a cardioprotective lipoprotein. So here we did an experiment where we activated endothelial cells in a grid vessel, and then we perfused buffer through them, and then after that an antibody against von Willebrand factor, and you can see that you form these strands all over there, and these strands all bind platelets. But if after activation, during the perfusion, we added ApoA1 to that perfusate, we got much less formation of these strands. And concomitant with lower self-association here, we also got lower platelet binding. So the platelet binding was proportional to the amount of self-associated von Willebrand factor. We have studied this in another system. This is microfluidics. This system was developed by Dr. Scott Diamond at the University of Pennsylvania, but we had a postdoc, Shirin Feghi, who is a mechanical engineer in the lab, and she to her, this was easy. She made this. So what it is, it's a microfluidic channel, 60 microns across, that in the middle of it has a pillar. This pillar blocks about 50% of the diameter of this channel. So you perfuse plasma through here, and it has to accelerate to get around the pillar. So when we perfuse normal plasma, so this is plasma with all of the plasma proteins, it's citrated to prevent it from clotting. What we see is these long strands that form on the pillar that extend downstream. These strands are very, very long, because you can see here, this is 30 microns. And we identified that this was self-associated von Willebrand factor that had gotten there from the fluid phase. When we took this plasma, the same conditions, and we added EDTA, which will inhibit the ADAMTS13 enzyme, what we got massive accumulation of self-associated von Willebrand factor fibers. If we take this condition and then we add HDL or ApoA1 to this, this is what we get, almost no strand formation. So this cardioprotective lipoprotein is very effective at blocking VWF self-association. We did an experiment in mice to see what would happen in a model of thrombotic microangiopathy, and that's like that disorder called TTP. So you take the enzyme deficient mice and you inject into them high concentrations of human von Willebrand factor. And normally what happens is, if you inject saline, of course, the platelet count stays high over the course of 6 hours. If you just inject the von Willebrand factor, the platelet count will drop, because they're all forming thrombi on the vessel wall, and they're being trapped in places like the lung. And you can see that you get a severe drop in the platelet count after 6 hours. But if you inject that von Willebrand factor in combination with HDL, you can see that you've markedly blunted the drop in platelet count. Concomitant with that, if you inject the VWF by itself, you can see that the VWF is lost, and that's because it's going into these thrombi. But if you inject it with HDL, the concentration stays much higher, because it's not being consumed either by self-association or by thrombus formation. Now, if we take that microfluidic device and we follow accumulation of these VWF strings over time, this is what we generally see, something like this. If we add an antibody that inhibits ADAMTS13, you get much faster VWF accumulation, something that we saw with the addition of EDTA in the previous slide. So I talked about HDL, high density lipoprotein, which is an protective lipoprotein, but the opposite is the bad cholesterol, LDL. What does that do to this process? We thought, well, maybe it'll do something, maybe it'll do nothing. So here's the normal again. This is with purified VWF, which we can then stain with a low concentration of fluorescently labeled VWF antibody. You can see that here's an accumulation of this VWF strands. The HDL almost completely prevents it. And if we add LDL, now you can see that you get massive accumulation of these strands. These we call Rapunzels, because of the fairy tale with the princess that had long hair that she could let down. So here's an experiment where we can actually vortex solution of von Willebrand factor. And when you vortex that, the shear stress will cause it to adhere to the wall and self-associate and disappear from the solution. So this is how much is left after 90 minutes. If we add 6 micromolar of HDL, you can see that you largely protect it. But as you increase the LDL that you add to this 6 micromolar HDL, you can see that that protective effect is lost. So really what's important here is the ratio between HDL and LDL. And if you double the concentrations of both, you can see that you get the same exact effect. Protection, and then that protection is lost as you increase the LDL concentration. And so Kimsey Platten in the lab, he did some quantification by doing Z-stacks and then quantifying the volume of these things. And you can see that in the presence of LDL, you get much, much more accumulation of von Willebrand factor in these strands. So here's an experiment done with plasma. And what we've done is we've taken the plasma and then tested it by itself, or we added HDL to increase the HDL-LDL ratio, or we added LDL to decrease the HDL-LDL ratio. And this is what we find. The plasma forms these. They're completely inhibited by the HDL in this plasma. So this is all in inter-individual variation. And if you increase the ratio of LDL to HDL, you get massive accumulation of these strands. And these look quite ugly. And here's just by fiber area quantification. And really with the LDL, what you see is that you get very rapid accumulation, and then basically it saturates. You can't put more on there. You plug up the channel. The fiber length in this case was not different, but the volume of the fibers is much, much greater. And what we find is if we perfuse into these channels and labeled HDL or labeled LDL along with the plasma, that you can see that HDL will bind here. Of course, this is, you don't see a lot of signal because it's prevented the strands from forming, but you can see here that you get a lot of LDL binding to these strands. Okay, so now we're interested in where does this LDL bind to the VWF? So the VWF is a multi-domain protein that in the middle of it contains these triplicated A domains, A1, A2, and A3. A1 is how VWF binds platelets. A2 is where ADAM-TS13 cleaves, and A3 is where it binds collagen, and that allows it to stick to the vessel wall under endothelial cells. So we thought that this LDL is likely to bind within the A2, and there's a region here that's a regulatory region that's between the A1 and A2 domains. And so we made two recombinants, one that contained that region, that's called the extended A2, and then another one that lacked it, that's the short A2. So we did size exclusion, gel filtration, and in these kind of experiments, big things you perfuse through beads, and big things elute first, so LDL comes out in early fraction. If you put in this short A2, it comes out in later fractions. If you mix these two together, this short A2 still comes out in the later fractions. If we do the experiment with this one instead, with the extended A2, now what you see, the LDL coming out here, the free extended A2 here, but you see this whole population of A2 that now has started to shift to bigger molecular weight, indicating or providing evidence anyway that the LDL is binding to this region of the A2 domain. Now, there are a number of lipoproteins that come under the category of LDL low density lipoproteins. And those include VLDL, very low density lipoprotein, LDL, of course, and intermediate density lipoprotein. When we purified all of these by differential centrifugation and tested them, what we find is that only the LDL was able to induce the accumulation of VWF strands. So we've looked at patients who have hyperlipidemia, so they have high levels of LDL. And these are from a lipid clinic at OHSU in Portland, our collaborator, Sergio Fazio and Natalie Pamier. So they gave us some patients plasma that had a very high LDL and some normal controls. And you can see that among the two, the HDL cholesterol levels were similar. And when we looked at the rate, the initial rate of VWF strand accumulation in all of these, we found a very strong correlation between the LDL concentration, and the rate of VWF accumulation on those pillars. We had one outlier that was strange, and this was a weird plasma for a number of reasons. So now I want to talk a little bit about some of the medical consequences of what I'm describing. So here, and this is work done with another collaborator at OHSU named Jonathan Lindner. He's a cardiologist, and he's an imaging cardiologist. And what he does is that he's developed a system where he can do ultrasound and image microbubbles. Those microbubbles can be functionalized on their surfaces to be able to bind to different things. In this case, there are two types of microbubbles. One that has the active A1 domain of von Willebrand factor. This will bind to platelets. The other one has the adverse, the GP1B alpha peptide that binds von Willebrand factor. And both of these can be used to image vessel wall surfaces. So here you see a 2D mode echo, and you see the aortic arch in an animal. This is a mouse that is prone to atherosclerosis, so you don't really see much. But when you look with bubbles that detect platelets, you can see that in these, this is, I think, a 20-week animal that's been fed a high-fat diet. You can see lots of platelet signal there, and this is the region of atherosclerosis. So 20 weeks. This is a lipid stain. So these are the plaques in these mice that have been fed a high-fat diet. And you can see the red there, by 10 weeks, they start to accumulate atherosclerotic plaque. By 20 weeks, it's greater, and then by 40 weeks, you have a lot. And along with that, you have accumulation of both of platelet signal. There's a lot of platelet signal here. Interestingly, if you take this, okay, so this is now this 40-week, so the one that looks like this animal that's given an infusion of ADAMTS13. So here's the platelet signal and the VWF signal at baseline. After 15 minutes, you can already see that it's dropping, and it essentially goes down to almost zero by 60 minutes. So this platelet signal on these plaques is held there by von Willebrand factor. So what are the consequences? So we did some studies to look to see what would happen if we give LDL with VWF. Now, so what we've done here is we've given the LDL by intraperitoneal injection 2 hours before we do these experiments, and then we gave the von Willebrand factor. This is human von Willebrand factor intravenously. We tried to do it with the LDL intravenously, but the mice died. They were probably getting clots. So what we see is now we're looking for platelet signal, and you see that the platelet signal goes up with LDL, goes up with VWF, and it goes up. It looks like it goes up further with LDL and VWF together. If we take LDL receptor deficient mice that are also deficient for ADAMTS13, put them on a high-fat diet, give them von Willebrand factor, you get a lot of signal on the vessel wall. The VWF signal pretty much parallels that. So this platelet signal is there because it's binding to the Willebrand factor. So what are the consequences? Okay, what about microvascular blood flow? As the platelet signal and the VWF signal goes up, it looks like the microvascular blood flow goes down. You can see here when we have the VWF, it also goes down here. And this has consequences for myocardial function. So what we're looking at here is global longitudinal strain. That's basically how much does the cardiac muscle shorten during a cardiac cycle, during cardiac contraction. This is in the ventricle. And you can see that in the animals that only receive saline, you get a lot of shortening, but that shortening is less. And you can see it more dramatically here in these double knockouts that are fed a high-fat diet. And what we see here is that the plaque area, again, correlates extremely well with, or the platelet signal correlates with extremely well with the plaque area. And these are just the different types of mice. And you can see that you have pretty much a straight line correlation. Okay, other things that we've done with this. So here's a very interesting experiment. This is another atherol-prone mouse called the DK, a double knockout mouse that lacks LDL receptor and an ApoB editing enzyme. These mice are given a heart attack. They're given a myocardial infarction here. And 3 days after that, you can see that there is a very high signal by microbubbles for platelets and a number of adhesion molecules. The control is down here. These are control bubbles. If you look at, so one of these is p-selectin, which is a cell membrane protein of endothelial cells. You can see here that post-MI, the p-selectin video intensity is very high. And so is the platelet signal or the VWF signal. If you give these animals ADAMTS13, you don't lose this signal, but you do lose completely the platelet signal. And of interest, the plaque in these animals, so this is in remote sites. So so we're looking here at remote sites. So they get a heart attack, and then you look at other areas of their blood vessels, and they start to make more plaque, meaning that the heart attack, the myocardial infarction, is actually pro-inflammatory and leads to increase in plaque at other sites. And this is well correlated with what's known about that a person who has a heart attack is at higher risk for the next 3 months of developing another heart attack or a stroke. And what you see here, this is the cremaster muscle. So this is far distant from the heart. The cremaster is in the testicles. And what you see is these are labeled platelets, and you can see that the platelets are adhering to the surface of the vessel. And in some cases, they form these strings. And sometimes you can see leukocytes come along and roll on top of the platelets. So these techniques and these collaborations have helped us a lot to kind of understand the medical implications of von Willebrand factor on the vessel wall. Here's another one. This is a drug, ponatinib, that is used to treat, it's a tyrosine kinase inhibitor that's used to treat patients with some chronic leukemias that are resistant to other, whose cancer is resistant to other tyrosine kinase inhibitors. And it's known that these patients who get this, they suffer many cardiovascular complications. So what we've done here is we've taken an atherosclerosis-prone mouse on a Western-style diet, and we've given them for, I think this was 1 week, this inhibitor, tyrosine kinase inhibitor, and we compare them to a vehicle control. And when we look at the platelet signal on the vessel wall, you can see that it's very high in the ones that are treated with the ponatinib. VWF is high, and the controls have nothing. The control bubbles. If we take this this ponatinib-treated animal and we treat it either with ADAMTS13, the enzyme, or with N-acetylcysteine, which we have also shown can remove von Willebrand factor from the vessel wall, you can see that this signal goes away. Both of these signals go down. The consequences of this platelet there are that there's a lot of myocardial dysfunction. Here, I'm not an expert in this, but you can see that this part of at the apex of the ventricle is not moving. That's called an akinetic segment. So the ability of the heart to squeeze is compromised. And when we look by microspheres for microvascular perfusion, here's a normal. You can see uniform green around, except where you have the cavities of the ventricles. But when you look at the animal that's been treated with ponatinib, you can see these dark areas. There are microvascular perfusion defects. You can see them all over here. And if you did an angiography to look at the big vessels, you can see that there are no large vessels occluded. So this is all microvascular dysfunction. So I've come to the end of my talk, and I just want to summarize now that this process of von Willebrand factor self-association has important roles in hemostasis and thrombosis. We think that it's necessary for normal hemostasis. We've shown that the ability of surface-bound von Willebrand factor to capture platelets depends on its ability to self-associate it into these thicker fibers and strands. And we've shown that VWF self-association increases with shear and elongational flow. It increases von Willebrand factor's ability to bind platelets. It's inhibited by high-density lipoprotein and ApoA1, and it's accelerated by LDL. And this endothelial-bound von Willebrand factor is involved in important human pathologies, including atherosclerosis and ponatinib-associated microangiopathy. And now to just acknowledge this, of course, was not done just by me. I'm involved in this, but I work with a lot of very talented scientists. And in particular, I want to point out Dominic Chung and Junmei Chen. We all work very closely together on all of this, and all of the people in our lab. Kimsey Platten, I want to point out here, has been really the person who's been doing a lot of the more recent self-associating studies. And, you know, this all started long ago with Jingfei Dong when we were working together, and he's now at Bloodworks. I also worked with people at UW, Ying Zheng, the bioengineer, Jay Heineke, and Tomas Baisar are experts in HDL and ApoA1, and my colleagues at OHSU, Jonathan Lindner in his lab, and Natalie Pamir and Sergio Fazio, the studies in the hyperlipidemic patients. Thank you, and I'll take questions.
Wow, Jose, fascinating. The visual evidence, the visual data, maybe one of the most compelling arguments I've ever seen to stay on my statin. So
yes,
really fascinating. Thank you. I'm looking at the Q&A. Let me ask people if you have questions, if you could please indicate in the Q&A. Let's see, I just see one thing in the chat.
Yeah.
So why do babies usually have no problems, thromboses, even though they consume a lot of whole fat milk? Does that have something to do with LDL, HDL?
Well, that's an interesting question. I mean, I don't really know the answer. I don't. Let me just put it this way. I don't think necessarily that having a high LDL means that you're having thrombosis all the time, but it will predispose you to thrombosis. So it'll lower the threshold of getting those thrombi. And you know, it's really interesting because the other thing is newborns, especially, they have ultra large multimers of von Willebrand factor in their circulation. So maybe this is so that they can survive a passage through the birth canal. I don't know. That's just speculation.
Yeah, very, very interesting. It was such a clear talk, Jose. I think there are very few questions.
Well, thank you.
Really just outstanding. I really want to thank you. Very, very, very clear, very instructive. We have a little certificate to send over to you, commemorating that your colleagues actually think so highly of you. They asked you to give this talk. I always say it's one thing to be invited someplace else, but from when your friends at home want to hear you give a talk, that's a real mark of recognition. So really appreciate it very much. We have one question that just came in here. Do you think we can use VWF staining to diagnose TMA?
Ah, that's from Keith.
Yeah.
Oh, hi, Keith. Yes, I do think so. And so what he's talking about is that thrombotic microangiopathy, TMA, it's a number of syndromes. right? And one of them is TTP, and that one it's clear. It's von Willebrand factor and it's platelets. But Keith, I'm very biased that a lot of the other ones also involve that, even if they involve other mechanisms. In the case of TTP, you have low ADAMTS13 activity, so low that it's almost, you could say it's completely deficient. But in others, it's also kind of low, and there are other things that will interfere with ADAMTS13 cleavage of VWF. And of course, you can have other things like LDL is high and your HDL is low that might overwhelm the ability of ADAMTS13 to cleave the vessel wall of VWF. I think that, yes, VWF staining is a good idea, and Keith is pathologist, so I think he should be doing that.
So the other question there, with the experiments where you perfused ADAMTS13 after a what, I'm not sure, it has a comment about competitive binding. Were you using it as a competitive inhibitor of binding?
Okay, I think, yeah, but the ADAMTS13, no, the ADAMTS13, I don't think competes with the VWF self-association. What it does, we believe, is that it cuts right in the middle of the self-association site. And so in general, what will happen is if you have a very, very long multimer, the point of maximum stress in the fluid phase will be right about in the middle. When that A2 domain unfolds, then it gets cut. If it gets cut before it gets a chance to self-associate, then you prevent its self-association. And we think that that's how it works.
Great. Any other questions? Oh, here we go. Is the effect seen with ponatinib a dose-related effect? And is this mechanism seen with other TKIs associated with arterial events?
Thanks for that question, Vivian. Yes, it is dose-related, and we only have tested, I think it was dasatinib, and that did not do that. So I don't know if any of the other ones. I don't know what is peculiar about ponatinib. We don't know the molecular mechanism, but it's doing something crazy, probably inducing VWF secretion and perhaps other things like, one other thing that I didn't talk about here, we've done a lot of work that reactive oxygen species can prevent the cleavage of von Willebrand factor because they oxidize the methionine at the cleavage site, and perhaps some of these agents like the ponatinib induce reactive oxygen species from these things like superoxide or things like that.
So the N-acetylcysteine experiment that you did, was that mediated, do you think, through glutathione, or was it not?
No, well, that's a good question. Thank you. In fact, N-acetylcysteine, the reason we tried this was because I was reading a paper about cancer-associated thrombosis, and many of the cancers that cause that produce mucins, and mucins are these long chains just like VWF, but it turns out they have VWF domains at the N termini and the C termini, and they polymerize in exactly the same way, and they can be broken down by disulfide reduction with NAC. And so we did a bunch of experiments to see if the same was also true of VWF, and it is, and it appears to work quite well at this.
Interesting, fascinating. I think we've got all the questions. We're about 5 minutes from the hour. We can't give you applause that you can hear, but thanks very much. I really appreciate it, Jose.
Thank you. It was a pleasure and an honor. Thanks.
Thanks. Bye-bye.
Bye.